First of all, I'm going to just look at a few figures that I've drawn out of the literature. I looked at the figures for Cyprus for diabetes from the International Diabetes Federation Atlas, which uses data provided by your Department of Health. So 7.7% of the population have diabetes. That's about 89,000 individuals. Their projections, indeed the projections of your health department, are that this will rise, so you're going to see another 41,000 individuals with diabetes over the coming 15 to 20 years. The absolute numbers here, of course, are smaller than they are in some countries, but all countries around the world are faced by this same problem. Among the published literature for specific papers, I found a report published very recently, which was a stratified sample of the adult population here from Cyprus, which gives a figure for prevalence for diabetes of 9.2%, which is using WHO criteria, and for pre-diabetes, 16%. Now, you heard earlier of the case of an individual with pre-diabetes. This condition was reversed, and this is a critical issue. The weight reduction is the most important component of the prevention of diabetes. And here you have 16% of the population, that's 1 in 6, who has pre-diabetes. We need to look at a few definitions. Helen gave you some figures for the amount of energy in the diet. We're normally thinking in terms of an 800-calorie diet, which is either 4 portions of a formula product or 3 portions plus food. We refer also, and the European Food Standards Agency published a report a couple of years ago where they suggested that in the future the term will be total diet replacement, where we replace all of the conventional food with formula diet. Most of our experimental work has been done in that way, primarily to take conventional food out of the food intake for a period of time, and then you very systematically reintroduce it as you move them into weight maintenance. There's also a term meal replacement, which is the term which is used in terms of the legislation that determines the composition for these products at the present time, and that is a formula product of 200 to 400 calories used for 2 meals per day with conventional food. There is a slight gap in the legislation at the present time because we're waiting for the European Union to produce a specific compositional recommendation for total diet replacement. We're still waiting for that at the moment, but this is where we stand at the present time. Now, this doesn't apply to most of you in the room, but in case you were wondering what your food intake would look like on a daily basis, a typical intake, if you're doing the total liquid total diet replacement, would be, for example, 2 soups and 2 shakes. Now, when I show that to my dietetic colleagues in the United Kingdom, they sort of look and think, I don't think people will be able to do that for very long. However, we know, and you know, many of you know, that actually individuals are able to do it, and the reason is because they change very rapidly. Within a matter of a week or so, they actually feel the difference. And this is one of the dramatic effects of this type of intervention. They can just encourage them to get through the first few weeks, and then they can stay on the program. They will get some extremely good outcomes. How do they work? Well, as you know, they work by achieving a larger energy deficit. The deficit is between the amount of energy that the body requires to maintain its present steady state. Although having said that, I know that many of you will have seen people who are not in a steady state. They're actually on a weight-gaining state at the time you see them, and you have to reduce them down from that point. But let's assume they're on a steady weight state. The energy deficit is 1,000 to 2,000 calories per day, and that compares with the conventional usual dietetic practice, if you're advising on a reducing diet, of a 500 to 600 calorie deficit per day. Therefore, you get greater rates of weight loss, and these are typically 1.3 kilograms per week in women and 1.5 kilograms in men. Now, around that figure, there's a wide variation. Some men will achieve maybe 2 kilograms per week, and some women will struggle to get to 1 kilogram. But these are the typical figures, and these come also from the big clinical trials that have been done. Now, the other key thing is that high compliance is achieved compared to conventional reducing diets. I can provide you with one research paper from Melbourne in Australia, which provides the exact figures, but when they were using their formula diet program, the VLCD, in that case it was, the compliance was very good. On the conventional diet program, a lot of people dropped out. There's also evidence that if you achieve a good initial weight loss, there would be a better 6 months maintenance weight. There is experimental evidence for that. Obviously, we'd like to have more evidence for a longer period of time. The American Dietetics Association accepts that one of the benefits of using this type of product is it helps those who have great difficulty with portion control. In your initial interviews with people, you would be asking them about their portion control and whether they achieve this or not, and so on. For those who have tremendous difficulty with portion control, some of you, I think, are probably thinking, do I have problems with portion control? Almost all of us do, to a degree, but it's the ones who have a real problem with portion control. And then finally, at the bottom of the list there, I put ketosis, and appetite suppression via the ghrelin hormone, which is released from the stomach and which signals to the brain that your stomach is empty and that you need to eat. Now, interestingly, we know that there are genetic variations in the extent to which this hormone is produced and the extent to which it causes effects. So some people are troubled by it more than others, but we also have evidence, again, it's from the Melbourne group in Australia, that this type of diet, which raises ketones in the blood, actually helps to suppress ghrelin, which makes people feel less hungry when they're trying to lose weight. So that's the mechanisms as we understand them at the present time. Now, in terms of nutrient composition, they, at the present time, conform to the European Union meal replacement specifications. Protein provided is 60 grams in 3 products, 80 grams in 4, very roughly. These are not very low carbohydrate diets compared to the ones that you might read about. So you're not giving just 10, 20, 30, 40 grams of carbohydrate. They're actually providing 60 to 80 grams of carbohydrate. Fat is not exceeding 30% of dietary energy, and as you already mentioned, one product provides a third of the micronutrients. Now, this is very important because we also know that people who are heavy are malnourished. This is an area that's been very largely ignored. You have to look in the bariatric surgical literature to find the data, and where it's been measured, you find that a proportion of people are vitamin C deficient, a proportion of people are vitamin D deficient, some are zinc deficient, some are magnesium deficient. In fact, a high proportion of them have some deficiency or other. And of course, we haven't got time to talk about the effects of bariatric surgery, which is a very good intervention for some individuals. But if you are malnourished to start with, you really ought to do an intervention which is going to correct the nutritional status rather than impair it. We have so far studied vitamin D status and vitamin B12 status and can confirm, and I can provide you with the papers, that you can correct the nutritional status with respect to those two micronutrients. The other key thing, and I mentioned it earlier, is that we now know that we have some specific targets to aim at. And there was a paper, a very large paper from the American College of Endocrinologists last year, in which they reviewed the literature such as it was at that particular point, and then set out some general targets for clinical practice for people who had obesity-related conditions. For pre-diabetes, it was a 10% body weight loss. For type 2 diabetes, 5 to 15% of weight loss in order to achieve remission or medication dose reduction or improved control. And then if you look down this list towards the bottom there, you'll see osteoarthritis, more than 10%. Slightly higher up, we were talking earlier on about fatty liver disease, non-alcoholic fatty liver disease, 5% to get rid of the fat from the liver, and perhaps a greater weight loss if there's a more advanced state in the liver. So we have some figures that we can now use. And the question I would ask, do you know anybody who can achieve these targets by conventional diet? It's very difficult. Most people with a good clinical practice in dietetics will be able to achieve that amount of weight loss in people with certain characteristics who are well controlled. There's scope for change, and they make the change and are able to maintain it. But it doesn't happen very often. It's certainly less than 5% of individuals. What we know from our work is that with this type of intervention, people who actually are compliant and do the program, they can achieve these targets. Now, I'm mostly going to talk about diabetes this afternoon, but I would just like to start with reference to osteoarthritis of the knees, because we are seeing an aging population across the globe, and age is a factor in osteoarthritis. We're also seeing people who are heavier and older, and so we are seeing an increasing prevalence of osteoarthritis. We're seeing increasing numbers of people needing to have knee replacements, hip replacements. Our medical management of osteoarthritis is not very good. We don't have any way of slowing the disease down or reversing it. All we have is symptomatic treatment, and we just allow people to slowly decay until they get to the point where they are eligible for surgery. And what that means in reality for individuals is 15, 20, 25, even 30 years of pain. Poor sleep because of pain, limited ability to move around eventually, and then also ultimately social isolation, which is not very good. So very briefly, I'm going to describe for you the Copenhagen weight loss in osteoarthritis trial. This was a randomized trial undertaken starting in 2007 on 192 people with obesity and with knee osteoarthritis. It was preceded by a small study which was not perfect from a statistical and design point of view, which is why we did this one. They were randomized to Cambridge Weight Plan total diet replacements, either an 8-10 diet, such as you use here, or a 4-15 diet, which was the very low calorie diet, such as it was used in other countries at that time. That was done for 8 weeks, and then it was followed by food reintroduction, roughly to about 1,200 calories for another 8 weeks. But during this time, these people also received education sessions on a weekly basis. Now, the setting is always important. This was a hospital research setting, and the people who were helping these people to lose weight were dietitians. And one of the key things that we're now doing is undertaking trials in different settings. So we have a study in Oxford in the United Kingdom where GPs refer out to Cambridge consultants, which will tell us how well people do under those circumstances. And as far as we're aware, they're quite likely to be shown to be achieving good results, but we have to wait and see. Now, what happened in this trial, this is the weight loss curves you see here on the left. The weight reduction was 12 kilograms in one group, 13 in the other. No significant difference between them at 16 weeks. So that point at the end of 16 weeks is the weight loss that's achieved, and then they were re-randomized to either one meal replacement per day to replace one conventional meal, or knee exercises to strengthen the muscles around the knee, or in fact no intervention at all. They were called back at a year for measurements, and as you see, the diet group gave the best outcome at 1 year, which was a maintenance of 11 kilograms weight loss. But it's also very important to note that in all groups there was significant reduction of pain as a result of the weight reduction, and that pain reduction was maintained for a year. Also, there was excellent compliance with this program. I've given you the dropout rates here. You see that in the diet program, only 1 out of 56 dropped out, whereas in the other groups it was slightly higher. And this is something that is seen consistently in all of the studies, that dropout is very low, compliance is very high. Now, I thought you might like to see this, which is an MRI scan using a dynamic system that enables you to look at blood flow and therefore information. It's actually the little fat pad that you have underneath your kneecap, and it's very difficult to feel. So if you check underneath your kneecap, there's a ligament which in most people means you can't feel that fat pad, but that fat pad becomes inflamed in osteoarthritis, and then signals which cause inflammation go into the joint and cause inflammation in the membrane around the joint, and that is what causes the pain. If you can reduce that using drugs, or in this case by using diet, which reduces the inflammation, then you will tend to switch off the pain. And one of the remarkable effects of this type of weight loss is the relatively rapid reduction of pain which is seen. I've seen some individuals achieve quite remarkable changes which really are quite transforming in terms of their lives. I've spoken to many of the participants in the Danish trial, and some of them were so dramatically changed that they said that they were never going to allow themselves to go back to how they were before, because they didn't realize how bad they were. This is something else that many of you in practice will have seen, which is that chronic diseases creep up on you. And by the time you're severely affected by it, you don't really realize how bad you are. And then when you're transformed very quickly, you don't realize, gosh, did I really become that bad? I didn't know I could be as good as this. And that's quite an important effect. Okay, so that's by way of introduction, but I'm now going to talk about diabetes. And the questions we're asking: can Cambridge Weight Plan prevent diabetes with sufficient weight loss, which we think is around 10%? Can we reverse early diabetes with an initial weight loss of between 5 to 15%? Can we improve metabolic control, reduce medication, and improve quality of life in advanced diabetes? Because, again, we perhaps have a tendency in practice, and I do work in a diabetes department providing the bariatric service, we tend to see the very worst cases who are towards the end of the disease process, and it raises the question, could we be more aggressive with our weight management among these people with very advanced disease? Nobody seems to be addressing this very much. So let's address these three in turn. Pre-diabetes. There is a very large trial which is funded by the European Union, and therefore you, the European taxpayers, in which in 8 countries, in Finland, Denmark, Netherlands, United Kingdom, Spain, Bulgaria, Australia, and New Zealand, there is a trial of a number of different dietary and activity interventions to see what is the best way to help people to maintain a weight loss in order to prevent and maintain that prevented diabetes for a period of time. The initial intervention is an 800-calorie Cambridge weight plan, liquid formula diet to achieve more than 8% weight loss, and the intention was to do it in 2,200 subjects. Now this paper is now actually describing the initial weight loss is ready to go off for publication, so it should be out very soon. There have been some preliminary presentations, so I can tell you some of the results. Very large numbers were screened. 2,326 people started the diet. They were on average around about 100 kilograms in weight. They lost 10.7 kilograms on average in 8 weeks. 3/4 of them have met the target that had been set of 8%. And the average weight loss was about 1.3 kilograms per week, which is exactly what we see in our normal practice and also in all the other trials. So what this has done is to replicate what we've seen elsewhere, but in this particular group with prediabetes. Now you're going to have to wait 3 months to see the results in terms of the metabolic changes, but I have seen them and they are very good. So I can assure you that you will be very encouraged when these appear. The second question was, can we reverse early diabetes? Now, in conventional practice, we think that once a diagnosis of diabetes is made, that's something you have to accept, and you then have to work your way through the sequence. But as Helen has already told us, this isn't the case. In ordinary practice, we do see this occasionally. In Scotland, a survey was done recently, Scotland in the north of England, and there are something like 300 people who are on the register as having gone into diabetes remission, but there are many tens of thousands of people who have diabetes which is maintained. Now, there are lots of complex slides that I can look at. I've just picked out one. This is from Roy Taylor's group in Newcastle, and I can provide the paper for you if you'd like to read it, and the other ones produced by that group. But essentially, he has used formula diet to take people with early diabetes, that's usually people who've had their diabetes for less than 5 or 6 years, and has achieved diabetes reversal when tested metabolically. But also interestingly, and this is one of the papers that shows this, what we're finding is that some people respond better to this intervention than others. And it is quite likely, I think, in a few years' time when this has been worked out a little bit more, we will be able to identify a person and say that individual is a good candidate for this intervention, where perhaps another one is perhaps not quite such a good candidate. Or alternatively, the ones who don't respond to the relatively short-term intervention, perhaps we have to treat them for longer, or add on additional therapies, perhaps. That's what we'd have to do. But the really good thing is that we do know that we can reverse and maintain reversal in a proportion. In this paper, it was 40% of individuals who were reversed. Now, for those individuals, that is really important. So, Roy Taylor's studies are good. They look at mechanisms, but they're not huge-scale clinical trials. So Diabetes UK, which is the largest diabetes charity in the United Kingdom, has provided their largest ever research grant so that a full-scale clinical trial can be undertaken. Now, it is being undertaken in the setting in which we need to deliver this intervention. So it's being done in primary care. It's being done by Roy Taylor in Newcastle and by Mike Lean and his team in Glasgow, and the initial weight loss of 15 kilograms is achieved with a Cambridge weight plan 800-calorie total diet replacement. These are the details. There is a protocol document which I can provide for you. There are a number of other related papers in this area, but you will have to wait until December the 4th for the results, because they will be presented at the International Diabetes Federation meeting on December the 4th, when we expect the full paper to be published. On the basis of what is already known from Roy Taylor's work, provided these people have achieved the weight losses expected, we would anticipate a good proportion of them will have been reversed metabolically back to normal, but we have to wait and see. So the next question is, can we improve metabolic control, reduce medication use, and improve quality of life in advanced diabetes? Now, this is the more difficult area to investigate. It's being done at the Hammersmith Hospital, Imperial College in West London. And I have some preliminary results for you, because 2 presentations have been made, 2 preliminary presentations. 20 obese individuals with type 2 diabetes treated with insulin. These people have had their diabetes for 14 years. They've been treated with insulin for just under 5 years. They were treated either with the low-energy diet, the 800-calorie diet, or what we've described as gold standard treatment, which is where they're given advice on the conventional 600-calorie deficit diet, which is given by the dietitian. All of that is done for 12 weeks, then food is reintroduced slowly on the low-energy diet. They're maintained then for a year. In fact, they're going to be maintained for 2 years. There was a presentation in Gothenburg at the end of last year, which gave some of the results. At 12 weeks, the low energy diet group had lost 9.8 kilograms. The gold standard group had lost 2.2. By 24 weeks, on that line there, you see that the weight loss then was 11.9 and 4.75 in the gold standard group. Now, if your eye drops to the bottom, which tells you about the insulin dose and the numbers who'd stopped their insulin treatment, by 24 weeks, 6 out of 12 people were no longer requiring their insulin. So these people were still insulin producing, but they were obviously insulin resistant, and by dieting you've made them less insulin resistant, and their endogenous production of insulin is then sufficient. And in the gold standard care group, one of them achieved that. Now this is at 24 weeks when food has already been reintroduced, so their energy intake has gone back up. Now we can't predict what will happen by 1 year or 2 years. Maybe more of them will drift back to needing insulin. And this of course is a slightly unusual thing to do because it isn't normally done in practice. But if this first randomized trial provides good evidence that this is possible, it will probably have to go on to a much larger multi-center study. But it does hold out the possibility that even people with advanced diabetes who are heavy and who are insulin resistant may be able to improve their metabolic state. And of course these people improve their cardiovascular risk profile, their blood pressures go down, lipid profiles improve, the atherogenicity of their lipids is less. All the various cardiovascular factors are improved by the weight loss and maintenance. So that is exciting. And I'm sorry I can't give you the final results, but it's never going to be the case that I can give you all the final results because there will always be something under development. So to summarize, in Cyprus, according to the figures that are available, you may expect about 41,000 new cases of diabetes. We know that use of very low calorie diet or 800 calorie diets can lead to reversal of early diabetes. And we know that a formula diet can be used to achieve the target weight loss of 15 kilograms roughly. And we know that the metabolic profile is improved. The weight loss we know can be followed by maintenance. Now, I described for you the Copenhagen study. There is a paper that will appear in the American Journal of Clinical Nutrition in about 3 weeks' time, which describes the 3-year maintenance after that initial 1-year weight maintenance. And I can tell you that those individuals did maintain 10% body weight loss for another 3 years. So we now have 4-year weight maintenance. It is possible to achieve it. And that's an important finding because previously people were anxious that, all right, you'll lose the weight effectively, but you're going to regain it, aren't you? That doesn't have to happen. If the right things are done, if the right education is put in right at the beginning, if the support is provided, as it is with Cambridge Weight Plan by Cambridge consultants or in the clinical setting by good interaction with healthcare professionals, which is a bit more difficult to achieve because there are constraints on spending, then it is possible. Effective fast weight loss is motivating. I've seen that many times. I know that some of you have seen that many times as well. Compliance is better, dropout rate is lower, and we expect rates of weight loss of 1.3 to 1.5 kilograms per week. So again, then finally to summarize, and there are other areas that I've not had time to talk about, we know that formula diet can deliver these amounts of weight loss, lots of evidence in the literature for that. We know that we have guidelines which give us targets. We have proven therapeutic benefit in osteoarthritis for 4 years, where the reduction of pain was maintained for 4 years. 1 year in obstructive sleep apnea, 1 year in secondary prevention of coronary heart disease, and 1 year in psoriasis, which is another inflammatory disease where we've shown that you can reduce the severity of the symptoms. Average 10% weight loss in pre-diabetes, that's very important. And then average 10% weight loss and 7% weight loss in the coronary heart disease patients. 10%, 15% weight loss and maintenance in obstructive sleep apnea. And then, of course, always there is total transparency. So all of the information is published, including the adverse event profiles. So they're also all very clearly defined in the public domain. So I will conclude then by emphasizing that Cambridge Weight Plan is an evidence-based program, which is proven to work in clinical trials. It's all in the public domain. A little bit is still coming through the system. But it's also based on the cases that we have seen. And I certainly in my practice have seen some amazing transformations of people's lives as a result of the enormous change that occurs as a result of big weight losses. I haven't had time to talk about pre-bariatric surgery or pre-any type of surgery. We have done trials before bariatric surgery and also before total knee replacement. And both of those show that there are benefits in before bariatric surgery. Of course, we can achieve liver shrinkage and reduction of visceral fat. I work with surgeons, and the heaviest patient we've had referred to us weighed 400 kilograms, which is 5 of me all in one person. Those people are very, very difficult, but we quite commonly see people who weigh 200 to 260 kilograms. And the surgeons are very often ask for 20, 30, 40, 50 kilograms of weight loss before surgery. You can't do that with conventional diet. We don't have drugs at the moment can do that. The only way you can achieve that in a patient heading for surgery is to use formula diet. And these are gradually being accepted by surgeons as a way of preparing patients. There's a lot of work to do in that area, a lot of clinical trials. I've got designs that we're working out with some anaesthetists at the moment to work out, because the anaesthetists are very happy if you can drop the weight of the patient by 60 kilograms. Much easier to anaesthetize, much easier to bring them round after surgery. So there are a number of areas that still need a lot of investigation, but it's all looking very promising. And so for those of you who are already involved, you're doing all the right things. I wish you success with what you do. For those of you who are not involved, and for those of you with whom we've had discussions this evening about new ideas, very happy to talk to you about new ideas. I think this is going to make a huge difference to the problem of obesity-related conditions throughout the world, and also, of course, diabetes, which is the major global challenge at the present time. Thank you. Thank you very much. Thank you. Yeah, sure. Yes, I think the time we're allowed to have questions, if that's acceptable. If there are any, I've got a whole string of reserved slides. You might want to ask some questions about something else. We could go on all night, of course, but we won't. Any comments or questions? I did. Let's just see where we can start. That's another slide that I'd like to show you, which is the scans which have been done in Copenhagen in the Arthritis Institute of the synovial membrane, which actually show that there's a very clear relationship between pain in the knee and the inflammation in the joint. It's quite interesting that this is the case. So we're not affecting the structure of the joint at all, it's actually switching off the inflammation. It's actually quite exciting that this is the case. A little bit more work needs to be done there. And the other thing, of course, and I talked about this with people before we started, that sleep quality is affected in osteoarthritis. And many of you, I'm sure, have got patients with osteoarthritis who just can't get comfortable. They wake up at night, they're tired in the morning. That drives depression, and they're really quite miserable. If you can transform them by causing a weight loss, it's quite a good thing. Any questions? Comments or questions? Yes, please. We've got a roving microphone. Can we have the roving microphone? And then if you could tell us your name and where you work, please. Okay. You want to get, or yes.
I would like to ask, is there any data on the treatment?
Yeah. When these programs were developed, the actual experimental work started quite a long time ago, back in the late 1960s and early 70s. The pattern of obesity in the world was very different, and childhood obesity wasn't the problem that it is now. And these were really designed for adults, and they're still presented as being for adults, and we normally are a little bit restrictive about the use in children. But however, we are constantly being asked by paediatricians, can we use this on this particular case? And there is a need now to do a trial, first of all on children aged 14 to 18. And certainly in my adult clinic, I receive patients at the age of about 17 and a half from the paediatricians, and we have some very, very large young people who have very typical patterns. We send them to Cambridge for genetic studies. One or two of them go to the Prada Willy clinic at the Hammersmith, but some of them have nothing specific, and it's really just, well, I'm sure eventually we'll find there are some underlying genetic features that play a part in their responses to ghrelin and so on. But there's one particular gene which I think is particularly interesting at the moment, which affects 1 in 6 people, which may be important to some of those individuals, but it's very often driven by their circumstances. They're very often single child, at home, spending 12, 16 hours a day in front of a screen, ordering in their food, so they eat lots and lots of pizzas. They're in a weight-gaining state, and very difficult to help. They need a lot of help from lots of different specialists. But it's an increasingly difficult problem, but we are asked. And I don't know how much experience there is here of helping people over the age of 14, but it's perfectly acceptable if the paediatrician or the general practitioner or internist is prepared to supervise it. When we start going down the age range, we'll have to start then looking at composition, because of course nutritional requirements are different lower down, and we'd have to sort of begin to think about a new composition. But it's a very challenging area.
Another special population is the nephrology patients, the chronic kidney disease patients.
Yeah.
How about them? Are they candidates for the Cambridge plan? Especially the end-stage renal disease.
Well, I think end-stage is a bit more difficult, and there what you have to look at is the composition of what you're giving in relation to what the requirements are. So what we normally say is the more advanced cases, we would work with the unit and tell them this is what is available, this is what you can use, and then the specialist dietitian and the nephrologist would decide whether or not it's appropriate to use it. However, in the less advanced individuals, it is possible to use these for weight loss. What we don't have at the moment is a good trial to determine the effects of a very good weight loss in specific subgroups of patients. So one of the groups that I've discussed both in Prague and in the United Kingdom is the live donor programs, because live donors are sometimes not allowed to donate because they're not metabolically acceptable, they're too heavy. And you could get an adequate weight loss and a complete metabolic reversal very quickly in a matter of 3 months. These people are matched, they're highly motivated, and we need to get on and do one of those. Nobody's done that yet. That needs to be done as soon as possible. And that would make a huge difference to the number of people who would receive transplants. And then you also have the problem of candidates for transplantation, some of whom are too heavy. Now again, that needs to be investigated by proper trials. To the best of my knowledge, it's not been done, nothing's been started yet, but it is under consideration. So that's a really challenging area, but there's a lot to do there. But there's a great need for some intervention for some individuals. We'll probably start with the live donor program, and then go on to the transplant candidates. Yeah.
The macronutrients of the diet is 40-40-20.
Yeah. Yes. But you see, they're not designed for renal patients. So I think, again, when we start discussing these programs in detail, we may well have to look at different formulations or different combinations of things and so on. So it's going to be quite a job. Yeah. Any other comments or questions? We could have informal discussion afterwards if you wish. Okay. Maybe. I think then we probably have finished. And so thank you very much indeed for coming. I hope that you go away as enthusiastic as I go away from all these meetings, because I obviously know a few things that you don't know, because I see the papers before they come out. And I can tell you that some of the results are just going to be amazing. There is one paper I work a lot in Copenhagen, so I've got a lot of colleagues there working on some of these aspects. And you can actually do some very sophisticated studies now. We do proteomics on some of these people, which looks at the proteins in the blood. The results are amazing. You get a good weight loss and you change, the inflammatory proteins go down, the pro-insulin resistance proteins go down, the other ones go in the other direction. The whole profile just changes very, very dramatically. Really is quite amazing. And those papers are available. You can have those if you want to read those. Okay, I wish you well. Thank you very much indeed. Thank you for coming.